with us. Welcome. Thank you for being patient with us and waiting for our connection. I'm Mary Hartog, the Programme Lead for the DBA, Doctor in Business Administration Healthcare Leadership at Middlesex University Business School. And we're running a series of seminars with Roger Klein and guests to talk about key issues, contemporary and wicked issues in the NHS, and the sorts of things that you may be challenged in your work and practice. Roger unfortunately can't see us today. His camera's gone AWOL, but he can hear us, and I'll be asking Roger to formally introduce Graham and start the proceedings in a moment. We would like you, if you have any questions, to put them in the Q&A rather than the chat, and we can then build on that. So thank you. And before I hand over to Roger, just to say to those of you who've been asking about the DBA Healthcare Leadership, we do have the web page up on the Middlesex website, and you can apply directly. What you don't need to do for a DBA or our doctorate in professional practice is put forward a project proposal at this stage. That actually comes later down the line when the programme begins. So all you have to do is complete the application form rather than the project proposal. But if anybody wants to have an informal chat with me, I'm really happy to do that. So I've been doing that over the last month or so to help you work out whether it's for you, what we'll be doing, how we'll be working, how we work with Roger and other associates, professorial associates who have healthcare leadership specialisms and experience. So please get in touch, and my details are on the invitation, m.hartog@mdx.ac.uk. I'm going to have a look in the Q&A. Catriona, if you can put any questions in there, we'll respond to that. Meanwhile, I'll hand over to Roger. Roger, welcome.
Hi, good afternoon, and apologies for causing chaos. My video camera has become very rebellious. So welcome everybody. We are very pleased today to welcome Graham Martin. Graham is Director of Research at the This Institute in Cambridge. He's got over 20 years experience in leading research to improve understanding of organisational change in the healthcare system. Amongst his recent research is the highly relevant, why do systems for responding to concerns and complaints so often fail patients, families and healthcare staff? If you haven't read that, I'd strongly recommend it. So Graham, thank you for joining us. Your research has made a significant contribution, yours and that of your colleagues at the This Institute, particularly, but not only, to the understanding of staff and patient voice. And your seminar, I think, today's seminar fits in quite neatly with our previous ones. One was on the experience of Black and minority ethnic staff in healthcare trying to raise concerns and whether they're listened to or not. And the second one was with Jill Mabon, who I think you know well, discussing her recent research on unprofessional behaviours. So I'm going to kick off with 2 or 3 questions, and then we're going to open it up to the chat. So if I may, the first question relates to the NHS staff survey that's come out very recently, which suggests there has been a slight increase in the number of staff who are confident their organisations would address concerns raised since last year after several years of decline. Do you think this means we can attribute the fall off to the effects of COVID and we're now recovering, or actually was what was happening before a more sustained deterioration, which will probably flatline?
It's a good question. I think only time will tell for certain. I think what's important, I mean, the NHS staff survey is a pretty high quality resource. It's not perfect, but it does get a lot of responses to it, and it offers both a snapshot, but perhaps more importantly, that longitudinal perspective about how things are changing through time. And I think over the course of the last decade, the 2010s, sort of post Francis and post Morecambe Bay, there was something of a trend upwards in terms of various questions asking staff about their views, essentially the openness of their organisations and whether they felt safe raising concerns, whether the organisations would take those concerns seriously. It was very gradual. And because of the size of the survey, you could say that it was actually hugely statistically significant. Whether or not it was practically significant in terms of the day-to-day experience of people in the NHS is perhaps more questionable, because it was small percentage point or half percentage point increases over time, but it was a trend. As you say, it then kind of flatlined and actually declined slightly in the early 2020s. And I think, to answer your question directly, undoubtedly COVID did have something to do with that. In all sorts of ways, all sorts of mechanisms might be associated with that, from just less time for organizations to listen, greater operational pressures undoubtedly, which mean they're less good at listening and less good at responding, and perhaps just a general sense that there was less psychological safety, that it was less easy to speak up. So the most recent staff survey, I think it came out last week or the week before. Again, it's a very slight change, but it is a change for the better. And we've got to welcome that. We'll see if that sustains through time, or whether it just sort of ups and downs a little bit. But I think the two key points I'd make are, one, yeah, it's a very slow process, this change. Number two, the absolute figures, never mind the relative figures from year to year, aren't that great. So I think we're still at around 62% of people feeling that it's safe to speak up about concerns. That rises slightly if it's a concern relating to unsafe clinical practice, to about 72%. But that's still, 1 in 3 or 2 in 5 people not feeling safe to speak up about those concerns. And then only about 50% of people feeling that the organisation would respond to their concern. Not sure how that benchmarks against other industries, and other industries don't tend to have quite such a good quality data source. But 1 in 2 people not being confident that concerns will be addressed is not great. And 2 in 5 people thereabouts not feeling safe to speak up about concerns, so worrying that they will in some way suffer detriment, is not good at all. So it's certainly not a time to rest on laurels. And then I think the third point I'd make, and this comes out in your work and in various other sources of information, is that it's not just the average that is important here. The average is useful, but it conceals as much as it shows. And there is very vast variation in the degree to which people feel safe speaking up in different types of organisation. And we know that some particular trusts, but also some types of organisation tend to have less open cultures. Ambulance trusts being an example of the National Guardian's Office, for example, has looked at. And we know that some staff groups feel safer speaking up than others. And we know, for example, again, persistent through time, that staff from ethnic minority backgrounds, again, your work shows this, don't feel safe speaking up. Fewer of them do speak up, and more of them tend to suffer detriment. So, there's a few things there. There's the overall trend, there's the absolute level, but there's also the variation, which is really important in thinking about how we respond to these issues.
Thank you. Quite a lot of food for thought there. Can I? When I go to trusts, one of the issues that organisations increasingly want to talk about is psychological safety, and everybody says they're doing it. Could you say a little bit about how important it is or isn't, and what else is needed to encourage speaking up in healthcare?
So, I think it's vitally important. It's a really neat concept. It's a really useful concept. And I think it's because of that neatness, that usefulness, the fact that it makes sense on a common sense level, not just as a highfalutin academic concept, is what's made it catch on. So I suspect everyone, who's on this call will have a rough knowledge of what psychological safety means, and their working definition is probably a pretty accurate one. It's something about being able to say stuff without feeling that you're going to be put down for that, marginalized for that, ridiculed for that even. So it's just that ability to speak up and raise concerns and know that even if you're wrong, it doesn't matter, because there's a sense that it's important and that we need to listen to people, and it's okay for people to get things wrong. It's okay for people to take that personal risk because that personal risk is mitigated. So that's huge, and it's entered that everyday lexicon, and it is really, really important. But I think there's a couple of things that I would say. So one is that it's great to create environments in which people do feel safe speaking up, but what that doesn't then speak to, no pun intended, is what happens next. So people are happy to speak, but does anything, what's done with that? How is it used? And this relates to my second point. Often how that's used is actually quite distal from the point of speaking up. So it might be that you're speaking up in the moment, something's about to go wrong, in an NHS context or in an operating theatre context. An extreme example might be someone's about to receive contraindicated medicine, or there's about to be a wrong site surgery or something like that. So and we know that in the past that has happened because people haven't felt psychologically safe, even though the knowledge is in the room. Issues like that have happened. So you do need the psychological safety, and speaking out in the moment is vital. And the team itself, the people who are right there in the moment, are able to do something about that. So psychological safety does the job. For lots of other things, what actually people are speaking up about, the people who need to do something about that, the organizational response happens somewhere quite far away from that. So it's all very well and good having psychological safety at the team level, but what then happens to that concern? And is the wider organization one that is also encouraging of people speaking up, is tolerant of people making mistakes, is tolerant of people speaking up in good faith and getting it wrong, and then responds in a way that shows that it values all those things rather than being scared of them or resistant to them. So it's really only a starting point, and it's something that operates at the team level, but an awful lot of these dynamics take place well beyond the team level.
So can I, this will be my last question before we see if there's some questions in the chat, and it relates to that really. So the response of the NHS to the Francis Review in 2015 was freedom to speak up guardians. And they were premised really on the idea that the key thing, as you've just touched on, was to make it safe and effective for staff to raise concerns. But there's quite a lot of research, including stuff from yourself, Mary Dixon Woods, Megan Wrights and others, suggesting exactly the point you've just made, that what really counts, the focus needs to be on what those who lead organizations say and do. Could you say a little bit more about why that's important, and what sorts of things leaders can do beyond what, in my experience, happens in many organizations?
Yeah, so I think again it's important because organizations are complex, and it's all very well and good knowing that your immediate colleagues have got your back, but everyone who works in an organization knows that that's not the only thing that matters. So there's wider systems and processes that go on, and regardless of whether your immediate superior or your immediate peer is going to listen to you and act on it, the rest of you can't separate that from the rest of the organization and the response that organization takes. And that's particularly important when it comes to raising the more difficult concerns, the ones that can't be resolved locally. So does an organization welcome that? Does it encourage openness? Does it listen? And does it close the feedback loop when people raise concerns? Or does it feel like you're really just taking personal risk for no good reason, that actually the prospect of anything good coming of speaking up is so distant that it's not worth speaking up at all? And these kind of things are set locally, of course. Individual departments will have their own cultures, and this relates back to the very first point, that the average degree to which people feel safe speaking up is one thing. It's the variation around that matters as well. So different parts of organizations will feel different, but the whole organization really matters as well. The other thing to say on that front, I think, is that this isn't a unique NHS phenomenon. This is something that affects any kind of complex organization, and all sorts of organizations can learn from people's insights at the sharp end of, or the chalk face, or the front line, whatever you want to call it, depending on the type of organization. And all types of organizations really struggle to make good use of that kind of knowledge. And again, Amy Edmondson, one of her colleagues, a guy called James DeTurt, who I think was a student of hers originally, so they've worked together on various things. He's written a really good paper. I think it's freely available. It's in the Harvard Business Review. So it's one of those papers that's aimed at a general, not an academic audience, but a general kind of interested senior leadership audience across different sectors. And essentially what he does in that is he calls on organizations to think very carefully about how they are approaching this whole question of openness, of voice and listening. And he says, you know, in response to all of those problems of closed cultures, of organizations, leaderships not listening, and of the disasters that have arisen from that, he says, okay, there's been an awful lot of response to that. Every organization now will have its confidential hotline, or its equivalent of a freedom to speak up guardian, or it's, you know, leadership walkarounds where you can get the senior executives coming to meet staff at the sharp end of whatever they're doing. That's all great, but a potential side product of that is that it kind of makes something of a special occasion a voice. And because it focuses on the big issues, the big ticket things, the really problematic issues, and trying to make sure that people speak up about them. And because it kind of puts voice on a pedestal and makes it seem even something that's, you know, unusual, atypical, out of the ordinary, it can have the opposite effect to what's intended. So, you know, things like, for example, confidential suggestions boxes, great up to a point, but the fact that it's confidential, what does that suggest about the organization? It suggests, you know, that this is a dangerous activity, or something that's only for the really important things that matter. Things like open door policies is quite critical of as well, because it's just a really, really passive approach. It's one thing to say, my door is always open. It's another thing for someone to actually come along and knock on the door, even if it is a little bit open, and take the time of it, of the executive. So his point really is quite similar to the point that you and Joy Warmington made in relation to racism in the NHS, is that we've got to get it out of the super special, you know, handle with care territory, and into something that, however difficult, we try to make part of our everyday conversations. So openness shouldn't just be about the big ticket issues. It should be something that we try to make the routine way we do business within teams, within organizations and beyond. Similar, race and racism shouldn't be something that we're scared to talk about. There's something that we have to handle, because we know that, you know, color blindness and approaches like that don't work. They just serve to reinforce disadvantage and make people ignorant of the privileges and the detriments that go on.
Thank you. We've got a number of questions coming in. I'd like to ask a question a bit later about patient voice, but if I may, if we go to a couple of the questions, if I start with a question from Joe, which is, how can organizations break down the hierarchy in large organizations to really hear what their staff feel about their organization? And one or two other people who are made similar points. So it's a bit more about hierarchy.
Yeah, I think part of that comes back to my previous point, really, that there's a lot of things, so there's a lot of approaches out there, and lots of them are very well intended, but you just have to be careful about how you put them into practice. And something which I've done some research on, and there's other studies that show kind of similar patterns in other sectors and in other countries, is around initiatives like patient safety walkarounds. So there's equivalents to this all over the place. So you have leadership walkarounds in other sectors. The Institute for Healthcare Improvement in the United States has come up with basically a protocol, a kind of instruction list for how you do patient safety walkarounds. And that's all great. And, you know, they're designed to kind of do what they say on the tin, to put people in senior leadership roles in direct contact with people at the sharp end of care. So that, and this is, you know, in the IHI's version of patient safety walkarounds, so that people at the sharp end can explain to them what the issues and the challenges are, what the patient safety concerns are. And again, following the IHI's version, what should happen then is that the people at the blunt end of care, the people in the leadership positions, listen very carefully and appreciatively to what people at the sharp end are saying. and commit to act on that. And then a few weeks later, they say what they've done, or they explain why they couldn't do something for whatever reason, because of budgetary reasons or other, things in the organization that mean that unfortunately that's the way it is. But they just commit to keeping that loop closed. So that's all great, and it sounds wonderful in principle. When you look at how these patient safety walkarounds often happen in practice, they just distort slightly from that, and they become something slightly different. And often they become a chance for people at the blunt end, people in those leadership organizations, to almost check up on what's going on at the sharp end. And it becomes more like a kind of an inspection or a little bit of extra surveillance, rather than what's intended, an open conversation. And so, our research, for example, and research in Canada found very similar patterns, that people often, that for one thing, these visits are done as surprises, unannounced visits, so that, the people at the sharp end suddenly feel on edge, and, this is something, we better respond accordingly. Or there's, questions that are asked behind the backs of staff. Patients are asked, is this really how things go on? Fine to include patients, but it's done in a way that kind of sets up that sense of conflict or divergent interests, rather than being done in a way that foregrounds learning. And from the point of view of the people at the sharp end, the more it happens like this, the more it feels like an inspection or an opportunity to roll out the red carpet, to put on a show, to, bit like the Queen or the King coming to visit. You've got to put on give everything a dust, put on your best clothes, make sure that everyone is towing the party line, and you lose that, essentially the main purpose of doing this in the first place. The opportunity for a frank, honest conversation about what's good, but also what could be improved and how we can go about improving it together. So I think the number one is to look at those opportunities and approaches and tools that are there to try and bridge that gap between the sharp end and the blunt end, and to make sure that you put them into practice in a way that doesn't necessarily follow a perfect script, but which at least stays true to the spirit in which they're intended. I think the other thing I'd say just quickly is that it feels like there's a particular role for people who have a sort of a foot inside the organization, a foot outside the organization. And again, if you look at some of the safety critical industry literature, it talks about these kinds of roles, about the importance of people who have inside knowledge of an organization, but also a sense of independence, and who are perhaps outside the line management hierarchy, and therefore aren't beholden to it in quite the same way. So I think in particular there's a role for people like non-executive directors, associate NEDs, maybe governors, maybe others, who are there for the organization. They're there to serve the organization. They're there to help it make it better, but they are not compromised in the same way, or perceived to be compromised in the same way, as someone who's directly accountable to, within the executive structure of the organization might be. So drawing on them, giving them opportunities to listen, giving them opportunities to have casual, unstructured, conversations without a defined purpose or agenda to them. That's really, really helpful in trying to close that gap between the sharp end and the blunt end.
Thank you. We've had 2 requests, and we've had an answer to the link to the Harvard Business Review article. So if colleagues who are listening want to get that link, it's in the chat, and we could probably send it out to people afterwards. I've got 2 more questions I want to work through before I come through back to mine, if I may. One is from Sheila Cunliffe, who asks, to what extent do you think the NHS is making long-term change to address issues? In other words, are trusts focused on how they can improve a particular score the following year, rather than addressing long-standing concerns?
I think that is something else that varies. Thank you, by the way, Jane. That is indeed the Harvard Business Review paper that I meant. So I think you do see, again, this comes from our research. We couldn't draw this picture perfectly, but there was certainly a sense that some organizations had a commitment and had a kind of a long-term framework in mind for how they were going to improve and how they were going to address openness, and others much less so. And I think, again, if you look at various sources of information, CQC ratings, staff survey, friend and family test, all sorts of patient surveys, there's often a very strong correlation actually between all sorts of different indicators, from morbidity and mortality, long-term patient outcomes, to things like staff's sense of openness, the well-being of staff, all sorts of other things. So there's definitely something to be said for a long-term vision, an integrative vision that brings together these different aspects of organizational performance and realizes that they are interdependent. I think what's really challenging for NHS organizations, and unfortunately we're seeing this right now over the last few weeks, is that so many of the performance indicators to which they are beholden continue to be very short-term. And we don't have to have a very long memory at all to know what kind of a distorting impact things like financial targets relating to emergency department throughput and so on had in Stafford Hospital in the late 2000s. They say that history repeats itself, but I never thought it would repeat itself quite so faithfully to the original. The kinds of things that are coming out from the central NHS, or NHS England rather, the NHS Commissioning Board at the moment, are so redolent of that, particularly around performance against the emergency department standard. And it's really, really strange that we've moved away supposedly from targets towards standards, and government seems to be talking about the importance of autonomy and of not running the NHS from the centre, but rather delegating and empowering leaders. And yet we have targets that are being used very, very crudely in that way to bash senior leaders with, to distribute money with, and so on. And that clearly isn't conducive to any NHS organisation or any organisation. No, I mean, I completely agree. And, we know that in some ways targets can be very effective. And I certainly wouldn't say for one moment that performance management in general, whether it's at organisational level or individual level, isn't a really, really important component of improvement. But it has to be handled with care, and it has all sorts of unintended consequences. And as you say, those consequences are sometimes behavioural, because targets or performance management, if done crudely, spreads fear, and that fear is contagious. And one person is under pressure, they will, unless they're extremely good at providing cover, tend to displace to some extent that pressure onto others. But there's also, the going beyond the sort of the human behavior dynamic of it, there's a sort of the systems dynamic of it as well. So if the operational pressures are being prioritized to such an extent in crude ways, and the overwhelming or the dominant metric is something like the 4-hour standard in the emergency department, then organizations that are following that metric and kind of responding essentially to the incentives, they're going to have unfortunate impacts on patient safety. So there's there's the behavioral implications, but there's also the direct tensions between providing a safe service and providing a service that gets through its workload in a way that aligns most closely with the performance metric.
Thank you. There's a question here from Jamie Mitchell, who says, so this is a fairly specific question about freedom to speak up guardians. There's always encouragement to speak up, but the guardians seem to, and this applies, I think, in a number of trusts, but probably not to all trusts, seem to pass on information to leadership, but people don't get the feedback. And there's not always the protection that people should have when they do raise concerns. Does your research say anything about how either organizations avoid that, or what staff should do to overcome these added barriers?
Yeah, I think so. One of the particular challenges here, I think, is that there's just so many different ways to raise concerns, or for people to, not even concerns, but for people to share information, try to share knowledge about what's going on. with organizational leadership. And I think part of the role of a freedom to speak up guardian is actually to sort of help people through that maze and to say, okay, so you've got this kind of concern, so this is what should be done with it. That's confusing in itself, and it can be off-putting in itself. So you do need someone to sort of navigate you through it. But also each of those routes to sharing knowledge tends to have its own kind of rules, terms of engagement, if you like. So particularly if something ends up in the HR route, let's call it, so if it is a concern, let's say, about an allegation of bullying, or just a concern about a colleague's behaviour, regardless of the patient safety and quality of care and kind of staff well-being implications of that, that's the kind of thing that can very easily suddenly become an HR process. And we know that HR processes, for good reasons, are bound by their own terms around confidentiality, around due process. It will undoubtedly bring in other parties, unions, whoever else, and very quickly that's something that can become subject to its own logic, and therefore not something that is going to be that the person raising the concern about will probably ever hear about again, or will only hear about if many months or years later, when the process has completed. So there are certain constraints on organizations in terms of what they can do and how they can close that feedback loop. I think, though, when they can do this, again, the research is very, very clear on this. It's the kind of thing that reduces that sense of futility. So whether it's incident reporting, or whether it's concerns raised through another route, wherever possible, it's vital for the organization to come back to the person who raised the concern in the first place. And even if they can't provide detail, and even, or perhaps especially, if the ultimate answer is, sorry, we've taken this seriously, but there wasn't anything we could do, that's all the more vital, because it shows that the organization is listening, that it does value that source of knowledge. And even if in a particular instance it's not led to a tangible impact, it's not just fallen into a vacuum and never to be heard again.
Thank you. I've got a question which I'm going to take in a moment from Nicola, but if I may ask a question myself, Graham, one of the papers, one of your papers reviewing the changes made to the NHS since Francis 2015, you say that they've focused almost entirely on staff voice and not the voice of patients. Can you say a bit more about, is that a problem? What should we do about it?
Yeah, so that was certainly the conclusion that we drew when we were evaluating the post-Francis. I think that the point I really wanted to make is that there's a lot of value added by a lot of what a lot of the work has done at Freedom to Speak Up Guardians, not just the work as imagined, in that they know the options available. They have a good sense of what a valid concern might be, when people who actually have those concerns in the first place might be doubtful about it, because we all doubt ourselves, don't we? If you see something that's an odd bit of behaviour, I think most people's first instinct to think is this a me issue, or is it really them? Am I just overreacting here? Is it just a one-off? Does this really matter? Is it really going to have an impact on patient care, on quality, on safety? And actually having someone to talk through an incipient concern with, and to see if it is actually a real concern, and if so, what type of concern, and if so, what the options are for me to do with it, is really, really valuable. So it's not just saying, okay, here's a list of 5 options, here's the pros and cons of each. It's offering much more of a kind of a curation of those options, and a dialogical process for making sense of a concern.
Can I take you back to, I'm going to put 2 questions together, one from Joe and one from Tendai, which are around psychological safety. So one is around how better can we create it, and perhaps linked to it is how can we evaluate it in a meaningful way, which I think partly touches on your, you've got to be careful with averages with psychological safety. Do you want to just say a little bit about that, Graham, or anything in particular you'd recommend people to have a look at?
I think so the second question, in terms of evaluating it, it's been a while since I looked at that literature, but I think that part of Amy Edmondson's work was actually to develop relatively objective, concrete, quantitative measures of that. So I think there are tools there actually for measuring psychological safety. Again, it's probably predominantly at team level, rather than above that. And as we were saying earlier on, team level psychological safety is important, but it's not the be all and end all. In terms of generating that quality and quality safety, in terms of generating that psychological safety, it's got to be multidimensional and it's got to be a team effort. So people leaders within teams, clearly, if they're not modeling psychological safety, if they're not daring to say things, acknowledging when they're wrong, bringing people into the conversation, listening to them thoughtfully, and whether they agree with them or not, showing that they value that contribution, that's really, really vital. But there's also a lot about, it's a team effort, and so it's people within teams as well who are really important. And all it takes is for one or two, snarky people in a team to be snarky or disrespectful, or to wear their prejudices on their shoulders. That can really, really disrupt that effort. So it's leaders play a clear role in this, but it's not just down to leaders. It's everyone who makes a psychologically safe environment. But then, of course, there's also the wider organization as well, and all the stuff that we've talked about in terms of the way that pressures at the top can filter down into things that are really discouraging of psychological safety. So, it takes place at team level. There's a place for everyone in that team to make a psychologically safe environment. But if they're in an organization that doesn't value openness, or that translates all of those pressures from outside and above into pressures on teams and individual team members, then psychological safety is going to suffer.
Right, I'm conscious of the time, so there are a number of other questions there and some really interesting points in the chat. Hopefully I've captured most of the ones, certainly all the ones that came in early. I'm going to hand back to Mary in a moment, but Graham, can I thank you? I've been scribbling away here. I know you can't see me. And can I say to colleagues who are listening that the work that Graham and his colleagues at this institute have done it is really kind of, to me, it's at the cutting edge of a lot of the research around voice, both patient voice and staff voice. And you might want to have a look at this website, because there's some cracking stuff in there which has very practical implications, even though it's very thorough, or maybe because it is very thorough research. I'm going to hand you back now, Graham, to Mary, who people will be able to see, to just round things off. And thank you again so much for joining us. Mary.
Graham, thank you very much indeed for your really informative conversation today. And Roger, thank you for moderating that conversation. It really did flow with the number of questions that have been asked, and there clearly is a connection with the 3 sessions that we've had around leadership, culture. I mean, lots of things here about culture and leadership in particular, as well as links back to diversity. And we can't hope to solve all the problems, but I think what you provided us with is much greater insight today about some of the issues around voice, and not least where organisational defensiveness, which is one of the themes that someone put in the chat about, well, how do we really tackle organisational defensiveness? And when you raise things like the legal sort of dominance of a response, rather than what we might call a more human response and measured response to some of the issues that are raised, we begin to understand what the limits of managing or breaking down organisational defensiveness and barriers might be. I just wondered, Graham, if you had any last words that you wanted to share with the audience before we bring today to a close.
Oh, Springer's final thoughts. Gosh, no, well, just sorry about the interruptions there, and I hope they didn't disrupt the flow of conversation too much. I guess yeah, one final thought, but particularly just bearing in mind the complexion of this audience. I think there's just a huge amount of pressure. There always has been, but it feels like it's no less intense and perhaps more intense now than it ever has been on senior lead teams in NHS organisations. And I've had conversations with executives and non-executives about the kinds of pressures that creates for them. And I think the only one thing I'd say that's really important is to remember that well-being, staff well-being, is for everyone. And it's really important to try to shield, to provide an umbrella from some of the stuff that comes from outside and above to staff. But it's also really important to foster that at a senior level as well. And, psychological safety applies in those senior teams, but so too does consideration for well-being. So I think be quite unashamed in thinking of your own well-being and in making space for conversations about your own well-being, and making space for yourselves in your personal lives and getting that work-life balance as well, because I think it's just really unenviable, and the risk of overwhelm is huge, and that has risks for individuals and for the organizations as well. So actually that's very Jerry Springer, isn't it? It's take care of yourselves and each other. I think it's important.
Well, thank you. And I think that's often a hard job for senior leaders in particular to grasp and to make time for themselves, because there are so many pressures on the job that they feel they have to respond 24/7 to the work. But part of the task is being healthy yourself, and then maybe having the empathy to understand how that impacts others in the workforce as well. So thank you very much indeed again, Graham. Really appreciate you making time to come and talk to us today at Middlesex, and to some of our students and a wider audience within our NHS network. Roger, thank you so much. Even though we couldn't see you, you did a splendid job. And Christiana, thank you again so much for handling all the technical for us. Thank you to the audience. Should anyone want to get in touch with me, please do on m.hartog at mdx.ac.uk. Thank you.
Thank you, Graham. Thank you, Mary.